Welcome back to Straight Talk with Tracey. I'm Tracey Masella. Thank you for joining me today. With me here today is Molly Norton, a licensed mental health counselor with a private practice in New Canaan and also a member of the Silver Hill Hospital staff. Thank you for joining me here today, Molly.
Thank you for having me.
We are going to be talking about OCD, Obsessive Compulsive Disorder. I'm very excited about this conversation personally. OCD is one of those psychiatric diagnoses that is thrown around to describe a lot of not psychiatric behavior.
Right.
So I wanted to first start with, at the very basic, what is the definition of obsessive compulsive disorder?
Okay, so very simply put, the definition of obsessive compulsive disorder is it is a psychiatric condition in which people experience intrusive thoughts, so unwanted thoughts, sometimes images that are very distressing to them. So they're bombarded with these unwanted thoughts pretty severely most of the time, and what happens then is they engage in a compulsive behavior or sometimes a neutralizing thought to get rid of the distress caused by the initial thought.
Okay,
So they get really trapped in this cycle of obsessions and compulsions because the compulsions are so effective at quickly neutralizing that intrusive thought.
And in terms of psychiatric diagnoses, what does obsessive compulsive disorder or OCD fall under? What category of disorder?
Right, so recently in the DSM-5, it now has its own category. It's obsessive compulsive and related disorders. So it used to fall under the anxiety disorders category, but they've recategorized it into obsessive compulsive and related disorders. So along with that, you have body dysmorphic disorder, Tourette's and tics, hoarding disorder. So those are in that realm now.
Wow. So what's the prevalence of actually diagnosed OCD?
So it's actually the fourth most common psychiatric disorder after the first three, which I think is anxiety, depression, and one other I can't think of right now. But it's very common, but it's underdiagnosed because I think there's a lot of shame and embarrassment. Some of the thoughts that people have are very taboo and they don't want to bring it up or talk about it. Some of the behaviors can be kind of embarrassing and secretive, so it's not diagnosed as much as it exists out there.
So that's really interesting. I was not aware that it was the thoughts that came first that led to the compulsive behavior. So if somebody you hear somebody that's very neat, right, and likes their house to be a certain way.
This is a pet peeve of mine. I know where you're going with this.
And that's like OCD, right? That's people say, oh, that's
I'm so
OCD.
Right.
Exactly.
Right, which is totally false and incorrect because that's, there's a difference between someone who likes to be organized and neat and they enjoy being that way and that's just like a sense of calm for them, and someone who gets incredibly distressed if something is out of place.
Right. To the point of debilitation. To
the point of debilitation, to the point of getting caught in those rituals for hours and hours, trying to make things symmetrical or organized, and if they don't feel it's just right, they're very distressed, so they get trapped.
Right. So what are some of the thoughts the distressing thoughts? How would you distinguish a distressing OCD thought from just a worry thought?
So intrusive thoughts tend to be kind of odd or strange. They tend to be against your morals and values in a lot of ways. So I think every single human being has strange, intrusive thoughts. I think that's part of being a human being. It's when the OCD sufferer will get very stuck on those thoughts and start to apply meaning to them. So have you ever had like a weird, just a strange thought that pops into your head and you're like, oh gosh, that was odd that I just thought about that.
Yeah.
And you let it go, right? Like it's kind of like, oh, that's just what my mind does sometimes,
right,
and that's normal.
Yes.
The
Self-disclosure, sometimes if I go over a bridge, I think, what would it be like to turn my wheel and go over the side of the bridge, right?
Right, and you're like, oh, that was, like, where did that come from?
Right.
So the OCD sufferer would likely get very stuck on that thought and think, well, maybe what if I actually want to die? Why am I thinking about that? Very distressed about it.
Right.
And then they find whatever the ritual is to make that thought go away.
Right. I worked with a young woman who was very worried that she was going to do harm to her pet.
Yep.
This young woman who was suffering with OCD, and that caused her so much distress because her pet was
she loved her
most
pet.
Beloved,
yes.
creature in her life.
Yes.
Yeah. So that kind of thought.
Right. So what happens is she has a thought that maybe she has an intrusive thought about like kicking her dog or stabbing her dog or something terrible. And she starts to think, oh my gosh, what if that means I actually want to do it? Am I violent? Do I have this part of me that actually wants to do this? And it's terrifying because obviously she doesn't want to do that.
Right.
So she might try and do some sort of mental ritual to make that go away, whether it's counting or doing something in her head to get rid of the thought of that. Or she may have to go check on her dog and pet her dog to make sure, she doesn't want to do anything to the dog. So there can be a lot of different ways that it manifests.
And so how do the behaviors actually act to neutralize those thoughts?
So it depends, because there can be so many different obsessions and so many different compulsions that, like in the case of checking OCD, which is the classic, I have to go back to my house and check that the door is locked.
Or the stove is off.
Or the stove is off. In that case, what happens is, so let's say I'll use an example with myself. I leave the house, I'm driving to Silver Hill to go to work, and I have a thought that maybe I didn't lock the back door, right? Am I sure I locked the back door? I think I remember doing it. If I had OCD, I would most certainly go back.
I see.
If I had this checking type of OCD, I would most certainly go back to check if my dog was okay and that the door wasn't open. I walk into the house, I have this immediate I see my dog is okay. I see that the door is locked. I check it again. I leave. I'm driving down the street again. Am I sure?
Wow.
Am I sure? Can I be 100% sure that I locked the door? What if my dog jumped up and hit the lock and now she's out and she's going to get hit by a car? OCD sufferer will go back again and again and again because
there's no relief.
There's no relief.
There's no fact checking that good.
Right. So OCD is called the doubting disease.
Yeah.
There's always going to be some sort of doubt, and tolerating uncertainty is such a huge part of treatment because we can't be 100% sure about anything in life.
Right.
And they want certainty all the time.
Yeah. Mm-hmm. So how would one recognize OCD either in their child or their adolescent or in a partner or in themselves? How would one know that it's time to seek treatment, that these worry thoughts or these doubting thoughts have become incapacitating?
So it depends on how much the person discloses what they're suffering from. I think a lot of times in kids and teens, there's a lot of time where they might be stuck in the bathroom or unexplained time where you can't find them because they're trapped in rituals somewhere. They may be hiding it, being late for a lot of things because a lot of times people get stuck in rituals and can't get to stuff on time. It can affect your job, obviously, if you're not able to get to work because you're doing these things again and again. So I think just being aware of repetitive behaviors. A lot of repetitive behaviors can be seen in other diagnoses and conditions, so you have to be careful about teasing things out. Like with autism, there's a lot of repetitive behaviors that might not be OCD.
Interesting.
Yeah, so there's a few other tics and Tourette's. Like there's a lot of repetition there too. So I think if you pick up on any of this stuff, you should just have the person assessed thoroughly, have them go in and see someone and get an evaluation so that you can figure out what you're looking at so you can figure out how to treat it.
Right, right. So how early can you start treating OCD?
At a very young age. Kids are treated for OCD as soon as it's diagnosed.
Right.
So the same treatment that we use for adults, which is exposure and response prevention, also works in children. It's obviously talked about in a little bit of a different way, in a more kid-friendly way, but it can be treated as soon as it's noticed.
As soon as it's observed.
And it should be. I mean, early intervention is always better. So.
Right. How we're going to talk about when we're going to take a break and come back and talk about the treatment, because I know it's a very detailed and prescribed treatment and very effective treatment. How did you become interested in this particular diagnosis and work towards having that be your specialty?
So before I worked at Silver Hill, I worked in New York City at a private practice under a psychologist. His name is Dr. David Rosmarin, and he had a special interest in OCD. He also treated a variety of other anxiety disorders, but he really had an interest in that, and I worked under him, so I developed an interest as well. And he, as a new clinician, he had me see some of the most difficult treatment-resistant patients that still to this day, have been my toughest cases. And I just really jumped into it, and I really enjoyed this type of treatment. I think because it's effective and it's measurable, I like it. I like it a lot. And I've seen people get so much better with it, and that's such a great thing.
You mentioned the treatment resistance, right? So are there folks that don't want to give up these rituals?
Yes, but mainly because of the extreme fear of what it will look like if they don't do the rituals. So
bad things will happen if I don't do my check-in.
Or like with contamination OCD, if I touch things that are dirty, I'm going to get sick and die. And I'm so afraid of that engaging in treatment where I have to touch dirty things is just too terrifying for them, or too overwhelming or difficult.
Okay, so we're going to take a break, and then we're going to come back and talk about prolonged exposure. No, exposure
response prevention.
Exposure response prevention. Okay, great. Thanks.
Sounds good.
For 1 in 4 Americans, mental illness hits close to home. And since 1931, Silver Hill Hospital has also been close to home. For individuals and families facing the challenges of mental illness, Silver Hill offers a highly trained, compassionate staff that provides state-of-the-art care in a beautiful and private setting. If mental health issues hit close to home, remember, there's a world-class psychiatric hospital right in the neighborhood.
Welcome back. I am talking with Molly Norton, a licensed mental health counselor and a member of the Silver Hill Hospital staff, and today we're talking about OCD. Thanks again, Molly, for being here. This is a fascinating topic. So we're going to talk now about the prescribed treatment for OCD.
Okay, so there's really two paths that you can take in treating OCD, or you can do both, which is usually the best. So you can, psychiatrists can prescribe medication for OCD, so antidepressant medication, SSRIs, are pretty effective in treating OCD. They can really take the edge off of the symptoms. And then there's the behavioral therapy, which is cognitive behavioral therapy, more specifically exposure and response prevention. So research says that the two of those things combined actually have the best outcomes. So taking an antidepressant medication and doing the therapy. However, if you were to choose one or the other, I believe that the research still says that the exposure therapy is a little bit more effective or important.
So what does that look like?
So it's challenging.
Yes.
It's a challenging type of therapy for people because it involves confronting your fears in a very systematic way. We like to start out small with the exposure piece. So that's, whatever the person's afraid of, we have to have them slowly face whatever that is. So to give an example, someone with contamination OCD who's afraid of germs or infections or viruses or whatever, it may be that they're avoiding touching anything that they deem to be dirty. So maybe that's taking out the trash, let's say. For them, taking out the trash means I'm going to touch this, and then it's going to get into my body somehow, and it's going to make me ill. And that, you can imagine, that spreads very quickly to a lot of different things.
Right.
So those people quickly become afraid of touching almost everything.
Right. And
So-
they certainly couldn't get on a subway or a bus or a
Right.
plane. Yeah.
Right. Anywhere that they can come into contact with certain diseases. I mean, usually AIDS is a big one. So like avoiding blood, avoiding any bodily fluids, that type of thing. So what we would do together in exposure therapy is we would create what we call an exposure hierarchy. Some people call it an exposure menu because it's a little more friendly than a hierarchy. You can kind of pick and choose
Okay.
the different exercises you do instead of going in a really strict order.
Okay.
But you'd start out at with an item that maybe produces a 3 or 4 out of 10 level of anxiety,
Okay.
right? So maybe taking out the trash, the person will tell you, okay, that's about a 4 for me. That's going to make me anxious, but it's not off the charts, and I think I can start there. So what you would do is you would have them touch the trash, take it out, do whatever they're going to do, and then prevent the ritual. So that's the second piece of thing. You have exposure, and then you have response prevention. So normally that person, if they did have to touch the trash, they may wash their hands, excessively after.
Okay.
They may pour bleach on their hands. They may pour alcohol, like rubbing alcohol, all over their hands because of the fear of whatever that germ was. So you would have them do the exercise and then not do the ritual. And what happens is their anxiety, of course, is going to peak. But when you prevent the ritual, that level of anxiety comes down slowly but surely. So what the ritual does is if you think of like peaks and valleys, so with the ritual, you have the exposure and you have that peak of anxiety. The ritual shoots
it
that
off.
peak down really quickly.
Right.
But that's so reinforcing.
That's
that
right.
that says to your brain, I need to do this ritual
It's the only
in order to
way.
be safe, in order to feel okay. So when you prevent that ritual, ultimately the brain learns, okay, I can do this without undoing it, without doing that ritual, and still be okay.
Right.
So your brain learns safety,
Right.
essentially.
So it's interesting that that's the same mechanism of action in the brain as problem behaviors, right? So if I feel an intense emotion, if I don't cut off that emotion, in my brain, I believe it's going to go on forever.
Exactly.
Right. So,
Exactly.
but some of these, I would imagine, and problem behaviors, you can pretty clearly say, well, long term, this is not an effective solution. But I would imagine it's difficult if you're saying, well, I'm just washing my hands. How is that a bad thing?
Right.
How is that a problem? I'm just washing my hands to be clean. I would imagine that there's some that could create some
Right.
some willfulness, right?
Yes, definitely. And there is a normative level of washing, and we
Right.
want people to be able to wash their hands normally because we
Right.
don't want people never washing their hands because that's not sanitary and that's
Right.
not what we do, right?
Right.
But people are washing their hands until they're raw and cracked and dry, and every time they go to touch something else, they're going right back to the sink. They're scalding themselves. They're showering for hours,
Right.
hours in the shower, doing rituals over and over again. So it's helping the person to get back to that more normative
Typical,
level.
right,
Because there
right.
are certain things that we do need to do hygiene-wise,
Right.
but we can't do them to that extreme level.
Now, is the therapist or the counselor or the psychiatrist working side by side? So would you be with the person while they are taking out the garbage? Or
yeah.
are they sent home? Okay.
Yes, well, homework is assigned.
Yes.
But I do a lot of home visits.
Okay.
I do a lot of exposure in session. Definitely, you have to, I think, in my opinion. So, sitting with a person and coaching them through it without providing too much reassurance is a challenge of this type of therapy, because reassurance is also something they seek. Am I okay? Am I going to be
Right.
okay? And you have to help them live with the uncertainty of, we don't really know for sure.
Right.
100% sure if you're going to be okay. But we
Right.
have to live with that because we can't live in a world where there's certainty. So that is a lot of coaching that happens. But yes, the therapy really needs to be done together.
Right.
At least until they figure out how to do it, and then they can practice it on their own.
Yeah. About how long could a person expect to be in that level of
therapy.
treatment? Yeah.
So it depends on the severity of their OCD. Some people come in with mild or moderate OCD, and they're in and out in 5 or 6 sessions. It's just
Wow.
sometimes just learning about OCD and what it is provides a lot of relief for the person, because they realize, oh, I'm not like a psycho killer. I'm not actually gonna hurt someone.
Right.
And wow, what a relief to just hear that from a professional. Like, no, you don't have that condition, you have OCD,
Right.
and you're afraid of your thoughts, and you're afraid you might do something that you're not gonna do.
Right.
But for people with very severe OCD, it's longer. I'd say in the range of 3 to 6 months, maybe, of treatment. Of
Still a
regular treatment.
relatively
It is,
short-term treatment.
yeah. CBT
Yeah.
and ERP, if done well, is a short-term treatment.
Wow.
Mm-hmm.
And does it go into remission? Do you see that at certain times of stress it might come back,
Yes.
even if you had managed it?
Yes. So being tired, being hormonal, being stressed, any of those things can kind of make this flare up. I always tell my clients to be, even when they're doing much better, this is a condition that you may have to deal with to some extent for the rest of your life, but hopefully it will never get as bad as it was. But you just have to be aware of it, and you have to remember the exposure therapy. And when something comes up in life, take care of it right away. Right. Don't start doing rituals again. Don't get trapped in the cycle again. Be aware and be fighting. So you're always fighting back against OCD. We try and help people look at it as an other, in a sense. So we'll have people give their OCD a name, because it's like a bully.
Yeah.
It really is like a bully, and you have to be able to fight that bully and say, no, I'm not listening to what you're telling me to do.
Wow.
Because I know it's not right for me, and it's going to make my life unmanageable.
Right. Sounds like there's some crossover between eating disorders and OCD. That eating disorder mind that's creating that.
Yeah, and I think with eating disorders, sometimes it's a little more egosyntonic. So it's not like with OCD, it feels very intrusive and very much like an other, and that it's happening to you. I'm not sure. I'm not an eating disorder person, so I can't be 100% sure about that. But I think eating disorders feel a little bit more tied up in their actual image of themselves.
Right.
But yeah, there is some crossover.
Yeah. Now, talk about misdiagnosis. So if somebody came into a therapist or told a doctor that they were having thoughts about, as you mentioned before, I want to harm someone, I want to kill my mom.
Right. So unfortunately, if you don't tease out the diagnosis and you don't recognize that it's OCD, I think you can do a little more or a lot more harm than good. So if someone comes in to see you and they say, I'm having thoughts about harming my mother, and they're considering it, and they're like, yeah, I really don't like her and I want to hurt her, that's a completely different thing than I'm having thoughts about stabbing my mom and it's really upsetting me and I can't stop thinking about it and I really don't want to do it. It's bothering me. That's more likely to be an OCD symptom pattern. So making sure, because if that's misdiagnosed and the person, the clinician says, wow, I think you need to be hospitalized, I think you might actually harm someone.
Right.
For someone that's deathly afraid of hurting anyone, that's gonna make them just, it's gonna traumatize them. Yeah.
So where would someone go for help? What are some of the resources that are available to folks that want to either learn more about it or find the actual treatment?
So I think the best place to go is the International OCD Foundation website. So that's iocdf.org. They're pretty much international organization on OCD. They have lots of resources. They have a find a therapist directory. So only the therapists that are members of that community will be on that list. They have tons of resources in education. signs and symptoms, what to look for. I think that's the best place to find resources for OCD specifically.
That's great. And finding someone who is skilled in exposure response is crucial,
Yes.
I would imagine.
It is.
Yeah.
And there's a lot of people who say that they do CBT and that they see people with OCD, but you really need someone that actually does. You should ask, do you do exposure and response prevention?
Right.
Have you done this before?
Right.
Because it is a specific type of treatment, and there's certain things about it that are tricky, and you need to learn those things through experience as a clinician.
Right.
So you would just want to make sure you're paired with someone who knows what they're doing.
Absolutely.
Yeah.
So for the parents out there, because I work with adolescents who say, my kids just got to buck up and do it, right? I just got to, if they're afraid of school, I've just got to get them there and they've got to do it. What would you say? Quick soundbite to give those parents.
This is OCD is really hard to have. It's really, really scary. It's really, really stressful. Ultimately, yes, we want the kid to face their fears, but to push them at a level they're not ready for is probably not the best way to treat it. Get them to see someone, get them to work on this, because ultimately everyone wants them to be able to go back to school and live their life and do all that stuff, but let's do it in a way that's therapeutic and not traumatizing.
Right.
Yeah.
Great.
Yeah.
Thank you so much, Molly. This has been,
welcome.
I always learn so much from these discussions, so thank you.
You're welcome. Thank you for having
I know this
me.
is going to be a really important show for people to watch because, as I said, this is one of those phrases that you hear thrown around that there's people get it wrong a lot.
Absolutely.
So, yeah.
And there's a lot of people out there that are suffering in silence,
Yes.
and there's no thoughts that are too weird. Get treatment.
Yes.
You can get better from this, and that's such an important thing.
Great.
Yeah.
We'll provide some resources for you folks on the website, and thank you again for watching Straight Talk with Tracey. We'll see you again soon.